Hello, I'm Dr. Linda Young, and you're watching Health Matters, put on by in combination with WCCA TV and the Worcester District Medical Society. With me today, we're very pleased to have Kimberly Foley, who is a nurse practitioner from UMass. This is Kimberly, and I'll give you a brief synopsis so you know who is going to be speaking to us today. She is a registered nurse. She received her nurse practitioner degree in 2014, and since that time, she has been working at the transplant department at UMass Memorial Health. She coordinates their Hepatocellular Carcinoma program. So today, that's a long word, and today we're going to be talking about hepatocellular carcinoma, which is a form of liver cancer. So that puts it in a little easier context, I think, for us to all understand. So I'm going to ask Kim if she could please go ahead and tell us about hepatocellular carcinoma.
Sure, I'm happy to. Thank you for having me.
Mm-hmm.
So hepatocellular carcinoma, as Dr. Young was saying, is a form of primary liver cancer. It is actually the third most common cause of cancer worldwide. Sixth most common cause of cancer-related mortality is related to primary liver cancer. So the thing about primary liver cancer or hepatocellular carcinoma is that it is a primary liver cancer, meaning it starts in the liver. So sometimes people get confused, that it starts somewhere else and spreads to the liver, but it starts in the liver.
Starts in the liver.
Mm-hmm.
It doesn't come from elsewhere in the body
Nope.
to the liver.
And unlike many other forms of cancer, sometimes people wonder, why did I get this? The most common cause for developing this type of cancer is cirrhosis of the liver.
So what is that?
Yes, good question. Cirrhosis of the liver is basically when, your liver is diseased, whether it's from many years of excessive alcohol use, hepatitis B, hepatitis C. There are many genetic forms of liver disease, hemochromatosis, Wilson's disease, a number of other things. And actually, fatty liver disease is becoming one of the more common causes of liver disease these days. But any of those disease processes over time cause damage to the liver, meaning it turns from a very smooth appearing organ. It becomes lumpy, bumpy, hard, it shrinks down, it becomes fibrotic, and it just doesn't work very well.
Can I just back up a little bit, and could you explain, what does the liver do? I mean, it's pretty important.
It is a very important organ.
What does it do?
The liver helps act as a filter for your body. It helps break down a lot of different enzymes. It helps with bile acid secretion. So when the liver is not working properly, people can get very sick very quickly. People can have problems with confusion. One of the more common physical signs is what we call jaundice, or when your skin becomes very yellow, the whites of your eyes become yellow. People can have problems with fluid building up in their belly. They can develop little varices on their esophagus, which can burst and bleed, vomiting blood. So
what's a varice?
A varice is it is an abnormal area in the esophagus that's caused from high blood pressure in the liver. When it's not functioning very well, it can cause pressure, which leads to the buildup of these little areas in the esophagus.
Sounds pretty uncomfortable.
It can be very uncomfortable for many people. So a lot of people get very sick with those problems from their liver disease. Other people who may not have those problems usually develop these little cancers over time in their liver. So they don't always go hand in hand.
Right. So hepatocellular carcinoma is a particular kind of cancer. As you had mentioned, it's the most common one. And is it really serious?
It can be. I think one of the things that we're seeing very common today is that patients are not always screened early enough. So at least in our practice, we're sometimes seeing that patients come in with incidental findings, meaning that it wasn't really sought out for. Patients will come into the hospital for another issue and have a CAT scan that shows something in the liver that turns out to be a liver cancer, and it's a little bit bigger or more advanced than we would like. But if patients are screened, if you know that you have risk factors for liver disease.
So what risk? You had already mentioned a few. Were there others?
Mostly any risk factor for cirrhosis. So, if you know that you have maybe used IV drugs in the past or have had a blood transfusion back in the 70s or 80s, you've never been tested for hepatitis C, it might be a good idea to get a hepatitis C blood test. It's easy enough for a primary care doctor to order. Hepatitis B, we see that a lot in patients who may have not been immunized. So a vaccine for hepatitis B is always available for newborns these days.
Yes, we start giving it when they're born.
Yeah, but
Yes.
Hepatitis B is very common in Asian and some sub-Saharan African populations. So if left undetected or untreated, hepatitis B can lead to these liver cancers as well. Having any excessive history of alcohol use over a period of time. Sometimes they're even saying that obesity and, high blood pressure, diabetes, the metabolic syndrome risk factors can lead to fatty liver as well. So,
yes, could you describe fatty liver?
Yes.
Because it sounds awful.
it can be unpleasant. I think, as I had briefly mentioned a little bit earlier, that's becoming one of the more common causes that we're seeing of liver disease. And I think, again, people who just maybe tend to be a little bit more overweight, less activity, an unhealthy or unbalanced diet sometimes can lead to high blood pressure, diabetes, cholesterol, and excess abdominal girth. Over time, those diseases can put stress on your liver as well, and the liver can become fatty, which over time can turn into liver disease or cirrhosis.
The poor liver. It does a lot
It takes
of
a
stuff.
hit. It can take a
It
hit.
can only take so much. Jeez. So are there certain populations or certain people that are more prone to this?
Yep. Yeah. Good question. Again, I think the most common causes for cirrhosis typically tend to be, alcohol abuse, hepatitis C, at least in the United States. And now there's more of a trend for this fatty liver disease. So if you're at risk, if you carry some of those other health conditions, it would be a concern that maybe you would be at risk for this. So if you're seeing your doctor and they do routine blood tests, they notice that you might have elevated liver function tests on a routine blood panel. Sometimes they do an ultrasound or just to see if there's anything in the liver that's causing it. And oftentimes that's when they find that the liver is a little bit fatty or even cirrhotic.
So I think one of the points for us to remember is when you do see your physician, you generally have a panel of blood work done. And it almost always includes liver function tests. So if you've seen your physician recently, if you're worried about this and you were told all your blood tests were normal, you may want to just specifically ask, did I have liver function tests? And most likely you did. And if they were all normal, then you breathe a sigh of relief. That sounds good.
Exactly, yeah.
Okay. We had mentioned as far as the cause of it, and you mentioned the risk factors, which are certainly the cause of this. And what sorts of tests are used? You had mentioned a CT scan, the blood tests, or anything else at all that could be done?
Yeah, so typically this cancer is found on screening, if you do have the risk factors, screening with an ultrasound. There is also a blood tumor marker called an alpha fetoprotein, or AFP for short. It's usually used in conjunction with an ultrasound or a CAT scan. And sometimes it can be very elevated if there's a lesion or a tumor in the liver, which kind of supports the diagnosis of a liver cancer. But sometimes some patients don't produce this blood marker at all. So, but it is something that we check.
Yes.
Because oftentimes if it is elevated, it just aids in the diagnosis, and it's something that we can follow over time.
So those particular tests you're talking about are not routinely done. They're only done should something come up with the screening? Or there's a risk there?
Correct, if there's a risk. So, many primary care physicians or general practitioners might not check the tumor marker, but if they see something, or, if patients are followed by a GI doctor or a gastroenterologist, they may be checking these tumor markers more frequently. But the AASLD, the American Association for the Study of Liver Disease, does recommend that patients who have risk factors for liver disease or liver cancer do have an ultrasound, which, is a non-invasive quick
Yes.
scan, and this AFP tumor marker every 6 months.
So I'll have you explain what the ultrasound is. Does it
Sure.
involve needles?
No needles,
Does it involve sedation?
no sedation.
Oh, that's easy.
It's painless, it's quick.
Okay.
They put a little bit of gel across the abdomen.
Is the gel cold?
I do believe most people warm it, but I can't make any promises. Good question. And the device emits ultrasonographic waves, which help look at the liver. And oftentimes we can look at the surface of the liver. A normal healthy liver is usually smooth appearing. It has a smooth shape to it. And somebody who has fatty liver or cirrhosis, usually it's a little bit more coarse or nodular appearing on ultrasound. So that usually lets us know that there's something not right in the liver. And ultrasounds are great at screening for picking up little lesions or tumors in the liver, but usually in order to diagnose a liver cancer, you need a special CAT scan or an MRI to give us a better contrast.
So
that does require a needle.
Yeah, I was going to say, those are a little more aggressive, but
bit.
Still, the MRI does, well, it depends where you go. You go in that tube.
I know.
I think it's important that we understand that there's definitely a procedure there that may lead you to that and may not. There's other ways to look at it.
Correct.
How about just on physical exam? Can you tell anything?
Not usually, and that's the other funny thing about this, well, not funny, but this type of cancer usually does not cause any symptoms. The only symptoms you may feel is if there is a larger mass, a tumor taking up space in your abdominal cavity, you might have some discomfort there. You might have a decreased appetite with some weight loss, but usually there are no symptoms, and it's kind of just picked up either through screening or, oops, I was in the ER and they did a CAT scan and found something. So,
is the liver bigger than normal?
It is. It can be.
But
it can be bigger than usual, and sometimes it shrinks down. But
so you really can't rely.
You can't really. You don't always feel. You can't always feel things on exam. No.
Well, that's interesting. So as far as I'm hoping we have to talk about treatment, because there must be treatment for this.
There is treatment.
So, and we can go into what's offered where you're working, but what kind of treatment is there for this?
So there are a lot of great options. If a liver cancer is caught early enough and it's small enough, we are usually able to successfully treat it with a number of, they are minimally invasive procedures. The caveat with liver cancer, most people think, oh, I have a tumor, can't you just cut it out with surgery?
Right.
We do that if possible, but the problem with primary liver cancer is that patients usually have cirrhosis too, so it's two unfortunate problems that can be tricky. In a normal healthy liver, you can actually cut out up to 70% of that liver and it will grow back.
Grow back, yes.
Which is amazing. That's why the liver is so great.
Yes, it is.
But with somebody who has cirrhosis, if you cut out the liver, it won't grow back. And it can actually put somebody into liver failure. So we don't want to do that.
Right.
But, having said that, some patients do, I think a small percent of patients do develop a liver cancer and not have a cirrhotic or diseased liver. So sometimes that is an option, but for many patients it's not. So we do try to target the tumors directly through a number of procedures that we do, usually with interventional radiology. They're all mostly day procedures, so patients don't normally have to spend the night unless,
So what's the difference between a radiologist and an interventional radiologist?
Perfect question. A radiologist is a very special type of doctor who sits in a dark room usually and looks at computers and looks at everybody's insides, and they are very skilled. They are usually the ones that are diagnosing these liver cancers just based on the CAT scan or MRI. They're very skilled, which is the other point I just wanted to mention. This type of cancer usually does not require a biopsy, which is another invasive procedure. We try to avoid that if possible. These tumors, these liver cancers usually they demonstrate certain features on a CAT scan or an MRI, which in a background cirrhotic liver or in somebody who has a history of hepatitis B or C, there's really nothing else it can be. So if the tumor or tumors has these features, we don't need to do a biopsy.
Well, that's good.
It is good.
Yeah,
It's one less thing, I think.
Yes. And is, as far as the biopsy goes, that does involve a needle, that I understand.
Yeah.
How, do you have any idea or any perception as to how often you can just rely on X-ray or MRI or CAT, it's really MRI or CAT scan
Yeah.
versus having to go in
Yeah.
with a biopsy?
Yeah, I don't have an exact number, but like I said, most times, if the tumors in the liver have these certain characteristics, there's a whole criteria that radiologists have developed. So if the tumors have certain characteristics and a background of cirrhosis, there's really nothing else it can be. So putting a patient through an invasive procedure that comes with a small risks of bleeding, we try to avoid that.
Yes.
But sometimes a biopsy is necessary if the tumor doesn't have all of the right characteristics. So we do that if necessary.
Is there treatment, if we can get into treatment a little bit now, if there anything else you wanted to go over? I think we've done screening tests and everything, the causes we've gone over. We talked about hepatitis B having a vaccine, so that's a
Important,
good part to that. So the treatment options you have gone over. Can you delve a little bit more into those?
Yes. Sorry, a little all over the place. But if surgery is not an option for a patient, interventional radiology, which are, radiologists, but they are trained to perform procedures, somewhat invasive, minimally invasive procedures on patients. They usually try to target the tumors directly based on the size of the tumor and where it is in the liver, if it's close to the lungs or whatnot, if it's, about 2 to 3 centimeters in size, something like that. They can usually go through the liver directly under a CAT scan or ultrasound guidance. Patients are put under general anesthesia, so they're asleep, they're comfortable, and they put a needle directly into the tumor and just apply heat or freeze or cold therapy, and they're able to burn or freeze the tumor out directly.
So other than the side effect from doing that, which is much less likely than if you were doing some kind of medication putting in there.
Correct. We try to start with local therapies to the tumor when possible. Sometimes that's not always possible. If patients have multiple tumors or tumors that are big in size, tumors that have started to spread outside of the liver, that's not always possible. Many patients are reassured to hear that traditional cytotoxic chemotherapy, like the really yucky stuff, doesn't work on this type of cancer.
I know sometimes there's specific markers that you can give a specific treatment for. Does that occur with this or no?
Not usually, no. So there's been a shift over the last 10 years, I would say. There really was only one form of oral chemotherapy that was found to work for a primary liver cancer, and it came with a lot of side effects. But over the last 10 years, many new forms of immunotherapy, which are given intravenously once every 2 or 3 weeks, that really helps to slow the progression or the growth and spread of this type of cancer.
Can you go into that a little bit more? How does that work?
Sure. So the immunotherapy drugs, there's a whole slew of newer drugs. Again, an infusion once every 2 to 3 weeks.
So infusion means it goes
in through an IV.
By IV, right? Okay.
Over a few hours. And it really just works to help slow the growth and spread of the tumor. It works on the tumor cells and just prevents them from growing and spreading. And
how successful is that?
It is pretty successful. I would say, we've seen an overall survival of an additional 2 years, I would say, in patients who receive this kind of therapy.
Does it ever get cured?
It's hard to say. I would say that for a smaller liver cancer that's caught early, technically it could be cured, but for how long, we don't know. Because usually the cirrhotic liver that has produced this tumor is still there. So we can burn them out or treat them, with radiation or that ablation procedure, but there's always a chance that it could come back or that another area could come up, which leads me to one of the curative options for this is a liver transplant, which is offered throughout Massachusetts at several hospitals. But that's a whole nother
Yes, we'll get into
a whole
that.
nother boat.
We'll get into that. So I'm fascinated by this because it's something that it starts with cirrhosis, well, usually starts with cirrhosis, which doesn't reverse.
No,
So you're kind of doomed. I mean, that's really awful to say, but
you are doomed.
wow, you have to be careful.
I wouldn't say you're doomed.
Yeah.
Cirrhosis is scary for many people, certainly, but once you kind of identify the cause of cirrhosis and if you're successful at avoiding those liver toxic things, any source of alcohol, when you have a known diagnosis of cirrhosis, just kind of accelerates the sickness that comes with cirrhosis. Avoiding, some liver toxic medications, we try to limit, some
right.
cholesterol medications can have an impact on
Yes.
the liver, excessive Tylenol use, things like that.
You never think about some of these things and how important.
I know.
Plus, I think just the anatomy of the liver, there's some important things that are tucked inside there.
Exactly.
So
The
pancreas
gallbladder.
and the gallbladder, and so
Yep.
it's a big organ, but does a lot of work.
It does.
So,
It does.
so tell me about what services you deal with at UMass.
Sure. So part of my role in coordinating the liver cancer program is we do offer a multidisciplinary approach to liver cancer, which many centers do offer. The benefit of having a multidisciplinary, meaning many specialties. So, we have our transplant surgeons, we have our liver specialists, also known as hepatologists. We have our medical oncologists, your regular cancer doctors, the interventional radiologists, meaning the ones that do the procedures to treat the tumors, diagnostic radiologists who interpret and diagnose the scans, and radiation oncologists who deliver external beam radiation, which is non-invasive and also an option. But we all meet, we review each patient case individually, and look at the scans as a team and kind of figure out which treatment option would best suit this patient based on how their liver behaves on a day-to-day basis, their other medical issues, and what the tumor looks like and where it is. Studies have shown that a multidisciplinary approach to treating liver cancer actually reduces mortality, meaning reduces death from liver cancer. It increases patient satisfaction because they feel like they're part of the team, and patients just generally do better. So we're happy to have this team approach to treating liver cancer, and we really do offer all of the treatment options that are available.
Right.
And we also have a transplant center, so
Yes.
we help patients with that as well.
So walk me through when a patient first shows up there that has been probably diagnosed to get to your facility. So walk me through what happens.
Sure. A patient would, unfortunately, if a patient is diagnosed with a liver cancer, if it's not diagnosed at UMass, we would, have their images sent over from wherever they had them done. We review their case in our multidisciplinary tumor clinic, and they would come to a clinic visit where they would probably see one of the liver specialists first, just to kind of get more information about their health history, figure out how their liver is doing, how they're functioning, how do they feel on a day-to-day basis, and those are other factors that we kind of think about when we develop a treatment plan for a patient. We usually try to have them see, the interventional radiologist or radiation oncologist if it is recommended that they have one of those treatments the same day.
I was going to say, this happens
We
very
try to
quickly.
do the same day
Yes, it's
to
not
meet
like-
everybody, and then it's not always possible with scheduling, but we do our best to make it more convenient for the patient. And then, our goal from the first visit to a treatment, we try to do 2 to 3 weeks, but that's also not always possible. But we really try to get patients in the door quickly to get this treated.
Right.
And then we put them on a surveillance program after. Depending on which treatment option the patient will receive, we keep a close eye, usually every 3-month imaging with an MRI or a CAT scan to make sure that nothing comes back.
So what's the most common treatment that you do?
I would say, any of the local procedures, again, they're offered based on the size and the location of the tumor, whether it's going in through the liver or going in through, one of the arteries to try to treat the tumor that way. They can actually put little chemo beads or radiation beads into the tumor. They're all very successful, and it really just depends on the patient and what what's
And
going
is,
on.
does that require staying in the hospital? Is it
No.
all outpatient?
It's all outpatient day procedures.
Which is also a very nice thing.
It is nice. It is nice, and it's usually, just a 1 or 2 visit kind of thing, depending on which procedure it is. External beam radiation is used for a lot of other cancers as well. It's completely non-invasive, but that is a bit more of a commitment. It's usually 5 to 7 visits over a 2-week period. So it really just depends on the patient.
Right. So it's not this very, very, very lengthy, the initial treatment, but then, of course, there is the follow-up that has to occur. So, but it's not like you start chemotherapy and you're on it for a year or something like that.
No, not usually. I mean, if a patient does end up on the immunotherapy infusions through a vein, it usually is somewhat indefinite.
Yes, that takes a while, yeah.
But again, that's why screening is so important, because if we can catch it early, we can usually treat it, and patients will usually do pretty well for the first few years.
We don't have much time left.
No.
So, anything else you'd like to go over? I think the services at UMass are I know there are other centers, but certainly for Central Massachusetts, this is a real big plus.
I think
They don't
so.
have to
Yeah.
travel into Boston
Yes.
or New York or
I know. I
other
just went into
places.
Boston this morning, and it was a lot of traffic.
Yes, yes, it's not very
Not
good.
always what it's cracked up to be.
Yes. Anything else you'd like to tell me? We have about a minute,
A
if that.
minute. Yeah, I just think that, sometimes as patients, we need to advocate for ourselves. So it's important to stick up for yourself. And, if you feel like you are at risk for something like this, and maybe your provider's a little hectic one day and doesn't always take the time, which they don't always have. But if you know that you have some of these risk factors, you can always ask for some blood testing and an ultrasound. It's
All
easy
right.
enough to do.
Well, we are out of time.
Oh.
So I want to thank you very, very
Thank
much for
you.
coming in. This is really interesting, and I'm glad I had a chance to meet you because I didn't know a lot of this stuff. So I did get to learn a lot,
Well,
too.
good. Happy to
So
help.
thank you very much. And we are almost out of time here. So thank you very much for listening. This is Health Matters from Worcester District Medical Society, WCCA TV. We're glad that you could join us today. My thanks to Kimberly Foley, who came and visited with us today to learn about this. Thank you.